You're watching Teaching Your Registrar to Deliver Effective Preventative Healthcare, produced by GP Supervision Australia and presented by Dr. Justin Coleman and Dr. Simon Morgan. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
Welcome along to what we think is a very important and, for us, a topic that Justin and I have certainly been very interested in over the years around preventative healthcare, around rational use of sort of tests and treatments and screening. In fact, I was looking just at the our title slide, and there's a picture of a blood test tube there, which maybe is a bit misrepresentative of what we're talking about, because we will be talking about screening and a little bit about blood tests, but of course, I think the majority of what we'll be covering is not the blood test that you might do following the guidelines in the Red Book, but...
Yeah, sort of interventions that matter, I guess, preventative interventions, and trying to measure them and compare them and see, in order that we can teach our registrars what matter more.
My name's Simon Morgan. I'm a medical educator with GPSA and also work for the RACGP, and I work actually at the local Aboriginal Medical Service here in Newcastle. And it's a great pleasure to be running this session tonight with a very dear friend and colleague, Justin Coleman.
Thank you, Simon. Yeah, I'm Justin Coleman, a GP in Anala Indigenous Health Service in Brisbane, and I've spent many years of my life in remote Aboriginal areas in the Northern Territory. Victorian, born and bred and trained initially. But yeah, I've long had an interest in preventative health. I've got a master's in public health and was chair of the RACGP Choosing Wisely working group when it was a thing, and I've sort of done a few academic articles on this sort of thing. So very interested in the topic, and it's lovely to be presenting it with Simon. I was also on the GPSA board for 2 or 3 years, so very much a big supporter of GPSA. So what we're looking at tonight, so Simon will be talking about us ordering screening tests and how, I guess, our concept of what is worth ordering. So a lot of it is about value. It's not about should you ever order this test, because often you should. Most tests that, the top 50 tests you should be ordering at some point. But we're interested more in should you routinely be ordering, should your registrar. The registrars come from a place where they've been taught by hospital specialists throughout most of their medical student career. Then they've done their various specialties and taught by, your liver physician about how to investigate livers really well, all that sort of thing. But your job as a supervisor is to almost detrain them in some of those highly intensive screening things, because they just don't work so well and in fact can cause harms. And then we'll look at how we teach that and look at, how do you have those discussions with your registrar? Do you have dedicated sessions where you talk about it, or do you do it in passing when you talk about cases? And then finally, we'll, and I'll run more of this second half there, looking at the actual interventions. So rather than screening, what do we do in terms of active health prevention as GPs? And again, this hierarchy of what do you tell your registrars to spend a lot of time in their consultation talking about? And if your registrars are talking a lot about things that probably don't make a whole lot of difference in prevention, maybe you teach them that their time is better spent doing other things.
I need to say at the outset that I'm a pedant, and that is not something that hangs around somebody's neck, as you probably know, but I think it's really important to differentiate the terms screening and case finding. And fortunately, it's not just me. The RACGP Red Book makes a very clear distinction between these two things. And my pedantry comes when I hear colleagues, registrars say, I have a patient with very, very difficult to manage blood pressure. They're on 3 agents, and I need to screen them for secondary hypertension. And I say, well, no, you don't. You're not screening them for anything. If you are doing this, you're investigating them, or indeed, you could say case finding. So screening is only when the patient is asymptomatic and you're trying to identify whether they have a disease or not. And this may sound, okay, Simon, you're just picking on the words, but in fact, it is incredibly important. And we're talking, as Justin just said, around high and low value. And in this situation, it's about high and low probability, because the probability, the pre-test probability of the patient having the disease, if they're asymptomatic, is of course significantly lower than if they're symptomatic and they're more likely, and you're indeed case finding they're at risk, or indeed they've got the illness. So that makes false positives much, much higher. So if we population screen on low prevalence diseases, we're going to get a lot of false positives. And that is where I think the term screening needs to be really clearly defined as opposed to case finding. So that's my little bit of pedantry, but I think an important one. Now, this, I guess, complements one I ran some months ago on rational test ordering, which is much more about diagnostics. And we talked a lot about the pressures to test. The Sunrise team, this is some years ago now, decided to run a sort of health check week where every day one of them showed their experience of having preventative healthcare. I could go through this in detail, I won't. Koshi had a PR live on TV for his prostate cancer screening. At the time, DRE was not recommended for prostate cancer screening, and indeed prostate cancer screening wasn't even recommended at all. There was a dermatological review by a dermatologist. Koshi went to a urologist. There was mammography and there was a skin check. And I guess the points that came out of this for me were that these media influencers were not only having non-guideline recommended screening tests, but they were heading off to their specialists to do it. So even if we're doing our best to try to screen rationally, it's a struggle.
Wondering if you want to define your phrase that Cocky had a PR screening live on television. Just some people might be eating their dinner. I'm imagining the worst.
It was from the front, fortunately, and just the grimace.
I
remember, I saw it. I actually did the research and had a look. You're reminding me, this is a true story, but a week ago I was driving around Newcastle here and I saw a van and it said DRE plumbing. And I thought, for those of you who don't know digital rectal examination, it's gone out of favour a little bit, that terminology, but there you go. And if that's not hard enough, our patients are bringing their own test panels in. But this is freely accessible. Patients may choose Sportsman Health or Checkup Advanced, including, as you can see, things like their CK, certainly their PSA, vitamin D3, estrogen and prolactin and cortisol for us to interpret. And are these screening tests? Well, possibly. Are the patients choosing or selecting these because they're symptomatic in some way? Probably. I mean, we're all tired. We all get headaches. So they market these things to the vulnerable.
Interesting take on that, which is going to appear more and more, of course. And someone approached me about 4 or 5 years ago from a smartwatch company and was interested in my take on them doing amazing screening tests on your smartwatch. And I think my response, being unenthusiastic, meant they never contacted me again. And I probably could have been my alternative career, I suspect. But yeah, the concept that your watch can, certainly measure some things, and no doubt things will keep increasing. And, instead of measuring your blood sugar once a day or your blood pressure or your oxygen saturation 5 times a day, it'll be able to no doubt want to do 10,000 times a day. But the question is, what do we do with that information?
So the point of putting this up is, for those who haven't seen it before, that it exists. But really there are all sorts of pressures that drive non-rational screening, despite the presence of really good guidelines. Now, Justin and I had a conversation about the inclusion of this slide. I've been putting this slide into this talk for 10 or 15 years now, and often it was with registrars, and increasingly the response to this slide was more and more muted, to the point where nobody had a clue what the pun was. But again, the point of this is that in your consulting room, no one can hear or see you screen. And so it is quite possible to order all sorts of non-rational tests that you might think are entirely reasonable, and I'm talking really from the point of view of the registrar here. My hospital career has driven me to think, well, if I can do the test, I should do the test. They haven't had that test for a while. But of course, tests are harmful. Tests are genuinely harmful. And the cascade of investigations that can follow inappropriate testing is very real. That was from the Archaeological Museum in Athens, actually. They're marble motifs carved by the artisans of ancient Athens.
And they've shown all the organs it's possible to screen for. So
isn't that? I mean, I thought that was a lovely collection. Just because you can doesn't mean you should, and that is without going through the Red Book, talking about a 55-year-old man and which tests we would do. It's an excellent evidence-based guideline that we don't intend to walk through, because you can do that yourselves with your registrars.
Simon, in space, no one can hear you scream. Was it Aliens versus Predator or one of those?
It was Alien, yes.
I do feel that those of us who feel we have special information and special knowledge, and we're different, and our patients are different to everyone else's patients, just because of our experience of a bad outcome, I do think that can very quickly tend to be unscientific. Screening tests, as opposed to treating things, screening for things is very, very hard to figure out what is worthwhile at a local level. Even if you see 20,000 patients in your lifetime, and sort of 2,000 of them who fit into a particular group you would screen, to figure out whether screening your patients is worthwhile is a huge, complex, logistical, statistical exercise, which ideally involves hundreds of thousands of patients, and people look at all sorts of harms, not just an anecdote of, I reckon I saved this person's life. And in fact, if you look at people who claim that their lives were saved because of a screening test, usually it's about 1 in 50 of the people who got screened for something, who found something, who had something treated, who were actually saved. So an example in mammography is that of the people who had a breast cancer detected on mammography, who wouldn't otherwise have had a breast cancer detected if they hadn't had mammography, 100% of them feel that their lives were saved, and in fact about 13% of them actually had their lives saved, so about less than 1 in 7. So in other words, it's very, very difficult to judge based on your own personal anecdotes how much your patients benefit from screening, for a whole variety of factors I won't go into now. But anyway, it's a fascinating and endlessly debated topic. Yep.
I certainly would encourage reading in this area, and encouraging your registrars to read in this area. Bias, and that is very much bias we're talking about, which is availability bias. I picked something up in someone by doing a full blood count, and they were anemic and had a bowel cancer. So now I'm going to do full blood counts on everyone every 3 months. I'm exaggerating, but those sorts of things do drive our practice. When I think Kanan is a really important point that, as Justin said, unlike diagnostic testing, screening does require these population sort of large studies. And so teaching by cases, but making sure registrars are aware of the guidelines. I would like to point out that we have just revised the GPSA teaching plan on this topic. I do think it's a really rich topic to teach. Let's spend the next 45 minutes as part of our teaching talking about preventative care, not just the screening, but the stuff Justin's about to talk about, as a bit of a standalone, and incorporate that into cases. But just as we move away from the screening side of things, you would be aware that the Red Book, the Guidelines for Preventative Activities, has just been revised after 8 years. I didn't realise it was quite that long. It's the 10th edition now. It's 377 pages long, so it's a very huge resource, but it's still very navigable. And really, we could spend a lot of time talking about the individual conditions. We're not. Bowel cancer screening age, I put this up because of two things. One, it has been lowered because the early onset colorectal cancer incidence is increasing internationally, but probably more so anywhere in this country. So we have a wonderful opportunity to complement the national screening program as GPs to ensure people have had their FOBTs. The lung cancer screening program has commenced as the 1st of July, so we've got an obligation, I think, to enrol people into that program. And again, we could talk about that, but probably all been to the education around that. And really, just to say remains very topical. This came from GP News this morning. Literally, as I was having my breakfast, I saw this. This is around population-wide genetic screening for conditions like BRCA and Lynch syndrome. So it's a very, very moving space, I think. And yeah, we've got this obligation, I think, to do our best to support our registrars. Similarly to the Red Book, the Preventive Guidelines for First Nations people in this country has also recently been revised. It's the 4th edition. I know Justin's worked on that document in the past. This copy, Just, or not?
Yeah. So I wrote the diabetes chapter in this.
Yeah. So anyone working with that population, or indeed seeing patients who identify as Aboriginal or Torres Strait Islander, those are specific guidelines. And again, registrars will be expected to know and to use those. A bit of a pivot from screening to more sort of broadly preventive activities in practice.
Moving on from screening, we're going to talk a bit about preventive intervention. So actually things which you do and you're going to teach your registrar to do. Most classic, probably everyone always does and knows about, is helping someone to reduce or quit their smoking. And the question is, what works best? Because we have limited time per consultation. So again, if the registrars have come out of a particular part of the hospital, they might be very familiar with, pediatrics and an intervention. I mean, arguably a vaccine is probably one of the most effective preventive interventions that society has, being currently destroyed in America and possibly with flow-on effects around the world. But that's an incredibly effective intervention to prevent future health problems. But we have a limited amount of time in our consults, and we don't really want our registrars, spending huge amounts of time and effort at the expense of other things on things that don't make much difference. So then it occurred to me, well, what actually gives us bang for our buck? Which preventative actions deliver the most health gain? If you were to scale them up, measure them one against another, there's many, many things we could choose from. A lot of them are good, but some of them are gooder than others. So that's my question. And to answer that question isn't overly easy, but there are some answers out there in the literature. So in particular, what I was thinking was prevention in terms of, particularly cardiovascular, metabolic type things. And we have on the left there, we've got lifestyle, is it more important lifestyle or is it medications? And within each of those categories, which of these things? So should we spend a lot of time talking about diet, bone up on what are good diets and hammer that with our patients? Mental health strategies, that might be medication. For mental health, that might be going for a walk. For mental health, that might be referring for counselling, doing your own sort of counselling. Weight loss generally, and of course with the rise of the GLP-1 and agonists, that's become a very expensive and marketed thing to do, which really it's another tool in our toolkit. How useful is that tool? Exercise. You can, there is so much evidence that the benefits of exercise, if you're sedentary, far outweigh any weight loss. So even if you don't lose a kilo, if you're exercising more and exactly the same weight, you're significantly healthier. And again, it probably taps into mental health. We go over to the medication. We've got, supplements. We've got vitamin D. I notice that's really risen amongst GPs and registrars in the last probably 10 years. I think it's probably ordered multiple times more now than it was 10 years ago. Is it worth putting a lot of time, effort at the expense of other things into it? Supplements, patients buy a lot of supplements. Aspirin, primary, secondary prevention, lipids, hypoglycemics, blood pressure medication. How do all these compare bang for your buck? And then, of course, even the concept of de-prescribing, which is healthful. And, there've been plenty of recent studies because it never used to be a thing. No pharmaceutical company ever sponsors such a study, but happily with increased, university and independent studies over the last 10, 15 years, there's a lot of evidence now that, if you manage to, they do it in nursing homes, they go around with a GP, a geriatrician, a pharmacologist, a pharmacist, and sort of halve people's medication. And the people they do that to do way better than the people who stay on 10 medications. The ones who are halved to 5 medications enter hospital less often, they live longer, they have fewer falls, they have a better quality of life, all those sorts of things. How do you teach your registrars about the relative value of these things? My question then is, why do we need to teach it? Because, we're learning it ourselves sometimes, and shouldn't registrars already know this stuff? Well, I think registrars do know a lot. They're very smart young folk, but they do have a skewed view, and that's they tend to use the sorts of preventions they're familiar with. So if they've just been hanging around the cardiology department, they'll go absolutely full bottle on lipids, and they'll put everyone on statin plus ezetimibe, highest possible dose. Is that appropriate for general practice? They tend to be influenced by the hospital learnings. I'll ask you, Simon, so anchoring bias in this instance, what are your guesses about what I mean by that?
For me, it's usually where you fix on one particular aspect of history or management, and it kind of overrides all the others. Yeah.
Yeah, no, that's right. So if you've just gone through a thing with them that they've seen you order a PSA test on someone, and they're thinking, oh, that's good, I can easily throw that on each blood test. They sort of tend to, because they're sort of anchored in this thing. A full screen for any male does involve a PSA. And then a way around that is to take them back to the Red Book and get them back to some sort of evidence. And then there is marketing. So particularly when medications are concerned, we're going to hear there are far more accurate statistics on the precise p-values and things on LDL levels and blood pressure levels and GLP-1s than there ever will be on diet and exercise, because there's a lot of money put into, studies of 5,000 people, because there's a whole lot of money to be made from it. And that because the evidence is out there and published, it tends to sort of overwhelm other evidence. The other thing is, I think it's worth teaching this stuff because not all prevention is equal. So if we want to aim towards those interventions that are fairly easy, don't need much time on the part of the registrar, because they're all, time pressured, and we can't have them adding in huge amounts of prevention into every consultation because they're already pretty slow generally and have a big effect. So smoking is an example. Whereas others, require more ongoing effect. They're still fantastic interventions, but is mentioning about exercise once to a patient or diet once in a 2-minute period, is that effective? And then the final thing is that I think it's situational. So particularly with medications, even though we're talking about population interventions, where we're sort of treating these things, in the end, the sicker people are, generally the more medications help. So, and again, they're coming out of a hospital system, they're coming out of, the evidence tends to be published on people with, very high blood pressure or very high lipids, and certainly the benefits are far more. And then we have to teach them the nuances of, how about your average, Joe Blow who walks in, who doesn't have terrible blood pressure, doesn't have a shocking diet but could be better, isn't a vegetarian, but on the other hand, their diet isn't terrible, all that sort of stuff. How do we sort of scale these? And the benefits of each of these interventions depend upon the risk factors the person has. Just the other way by way of background is just that what is useful sorts of statistics to look at. Stats, of course, can be bent to everyone, however you want to bend them. I find that these two in particular are quite useful. So that's your absolute risk reduction and your number needed to treat. The reason I say that is because these depend very much on the population you're seeing. The relative risk reduction, so just to put it very simply, if you work in a cardiology department And, people are 10 times more likely to have heart disease, probably 50 times than the population in general practice before the screen. And you have an intervention that reduces the risk of something by 10%. That's going to help, almost 1 in 10 of those people who turn up to the cardiology department. But of course, of the next 1,000 people your registrar sees, probably 900 of them are never going to have any heart things. So really, instead of helping 1 in 10 of those people, it's only helping 1 in 100 of those people. And so the absolute risk reduction is what's important. The relative risk of that 10% improvement depends hugely on the population you're dealing with in the first place. The number needed to treat also takes that into account, meaning of the patients your registrar sees, how many patients will they need to intervene for how long to get one good outcome. So a classic outcome is to prevent a death, very easily measurable. Another easily measurable one is called MACE, which is sort of major adverse cardiac events, which is sort of heart attack, stroke, and that sort of thing. So those sort of outcomes are very useful because they're easily measurable. And if you have to treat just 30 people with a simple intervention to reduce one of those things, that's fantastic. If you have to treat 500 to reduce to stop one person having something that's not a death, but something nasty, that's maybe not so good. All right, that's just a bit of sort of evidence-based background. My apologies for giving that to you later at night. We'll have a bit of discussion about this, but in general, what I would call a high yield intervention for your registrar and for you, of course, is something that's a low number needed to treat. So in other words, you only need to give a few people this intervention and you'll find that you get one good outcome from those few people. So a low number needed to treat. And the outcome really matters. Clearly, stopping a death and stopping a heart attack really does matter. Making someone feel a bit better on a depression scale, it maybe matters or maybe not quite so much, depending on how much better they're feeling. So and then low effort and cost. So you want your registrars doing stuff, ideally, if they can do something in one consultation for 5 minutes spent on it. That's a low cost of time. It's a low cost to the GP. It's a low cost to the patient. They're not rushing off doing 15 other appointments and tests and visiting specialists, as opposed to a high cost thing that can be monetary cost, a new expensive medication. It could be cost by sending them off to a series of outpatient appointments or specialist appointments that are going to take up a lot of that patient's time. It is hard to gather this stuff, but I've used quite a few references and done my best. So I think top of the pile does come smoke advice, because for a brief intervention, which is essentially free, takes not too much time, and the number needed to treat is really depending on how long you spend and all sorts of other factors, somewhere around the 30s to 40s really, and then in some cases up to 100 for one extra quitter, and then each quitter you get about one life saved per 8 quitters long term. High yield because this is really someone who wouldn't have otherwise quit if that GP had not talked to them for 2 or 3 minutes about quitting. So, to me, that's a very time well spent, and it's high yield, high value. Another high yield thing is actually blood pressure medications. So for people, and the yield is highest for people with very high blood pressure. For people, once you start arguing, well, is 140 hypertension or is 130 hypertension, it gets more and more nuanced and the numbers needed to treat go up. But certainly for someone with genuinely high blood pressure, you get this, significant drop. And the medications are, generally you can find one they tolerate pretty well, and they're pretty cheap. They've been around a long time. There can be side effects, but we tend to know them fairly well. So BP is another high yield thing. So get onto people's blood pressure. And the third high yield thing is the statins. And you can see some of the stats there. So remembering that the advantage, the absolute risk depends on the background prevalence. So that's why I've taken someone at 10% risk If their 5-year thing is 10% risk, then I've come up with those numbers. The absolute risk varies. Again, you get more bang for your buck at someone at 15% risk and less bang for your buck at someone at 5% risk. Which is true of all these interventions. So biggies, smoking, BP and statins, they're definitely high yield, worth looking at. Discussing exercise, I love discussing exercise. As Simon knows, I'm a mad keen runner, and I love exercise, and it makes you feel better for so many different things. Couldn't tell you how much good exercise does. However, if you look at the actual time, the intervention of a GP in one consultation talking about exercise, the data is sort of not that strong. So if a GP gives a prescription, says to exercise more, gives motivational interviewing, Cochrane review, they looked at of people whose GPs tended to do that sort of thing, but it wasn't a structured program. At 12 months, they averaged 14 minutes per week more than others, more than the other group of moderate to vigorous, which is okay, quite good, not brilliant. It's hard to define the number needed to treat. It's certainly a lower yield than giving smoking advised BP meds or statins, which is sort of disappointing. The good news, though, is that if you do a lifestyle program, if you do more intensive exercise discussion, and that can be, so for many of us, many of the registrars, it'll be referring to an exercise physiologist or something like that, or referring to a walking group where they actually take it up, or a sports group. Or for some of us who are fully into exercise, it may be yourself seeing them over a period of time and getting them motivated. It depends on your own special interest. For that, there is and this is just one of the many stats, pre-diabetes to diabetes, it more than halves the progression. And number needed to treat of 7 over 3 years is a fantastic number for preventing diabetes. So in the end, I guess the answer is that if, because of what you or the registrar does, they actually join a program or start exercising or do something regularly or get a gym membership, then it's in fact becomes very high yield. The reason it's not super high yield is it's watered down by all those people you say you should exercise and they don't actually do those things. So that waters the whole thing down. But of the people where it actually works, it's fantastic yield, and in fact it's very comparable to the previous slide. Not so much the smoking, but certainly the BP and lipids, the results are there. Just to compare that, because I mentioned going from pre-diabetes to diabetes, and pre-diabetes to me is not an important diagnosis, in all honesty, and I do honestly write a lot of book chapters on diabetes. To me, it's just this metabolic risk thing, and people are in this metabolic risk phase, and it's like, low exercise, too much weight, sugars go up a bit, lipids are up a bit. That's just the person we're talking about who doesn't actually have diabetes. So that sort of person, if you put them on metformin, you need to do that for twice as many people to get the same benefit as if you get them on some sort of exercise program. In terms of nutrition, then again, this is sort of in the same boat as exercise for a single GP giving advice. So, and I do it all the time. I'm very happy I encourage my registrars, always talk to them about their food, but we have to be honest as to how much that helps, that unless you're reinforcing that the efforts do fade a bit, there's not much evidence for that very down the track endpoints for GP single advice about diet preventing heart attacks, which in some ways isn't all that surprising. And so they have less yield. What does have yield with nutrition is, again, this sort of structured program. Now, again, they measure it by, usually they do these studies by going to a dietitian. The same effect, there's no reason to think the same effect wouldn't be the case if you yourself have a particular interest in nutrition and diet, and you're the type of GP who gets people back and shows them things and demonstrates diets and that sort of thing. You too can have the same influence. I don't do that. I tend not to have the time or the skills. Plus, I have a dietitian at my practice free on hand who's better at it than me. So I tend to do that. But so for these structured programs, there's a huge differences. I won't go through them all, but the numbers on this screen are very impressive. And that's a lot higher yield than brief advice. So that's with the dietitian. Moving to medications now, aspirin, primary prevention, it doesn't actually work. The number needed to harm is actually lower than the number needed to treat. And so really, whereas we used to, say we should put aspirin in the water, or things like we should give everyone with diabetes aspirin or something, that's actually wrong. We shouldn't. It really does come down to primary prevention versus secondary. Once you get to secondary prevention, the numbers needed to harm are roughly the same, and that's causing bleeds. But of course, the numbers needed to treat come right down, and therefore it's a very useful medication. It's also, it is cheap. It's been around a long time. It's not much cost to it. So aspirin, there's a huge difference between primary and secondary prevention. And just to finish on it, the last couple here, the GLP-1s, your Ozempics and things, the jury's still out. They probably have a lot of benefit, but we're not quite sure in terms of primary prevention, in terms of someone who has obesity and nothing else. But certainly for someone who has obesity plus diabetes plus this whole metabolic thing, they do seem to be very effective, and there's a 20% reduction in major cardiac events. Interestingly, vitamin D, which I threw in there, I thought I'll throw in one supplement. There's lots of other supplements people take, and some registrars feel are really important to talk about. But in general, no supplement is anything like any of the things we've talked about. So, and that does include vitamin D. It really, if you look at the association between it and people who are sick, there's a very strong association. But if you look at any population group and adding in vitamin D versus the same population group and not adding in vitamin D, in fact, the numbers needed to treat are very high to prevent a fracture. And in fact, it's just not as impressive as perhaps we're told. So there's nothing wrong with testing vitamin B and doing something about it, but you have to realise you're just not doing the same amount of good as you are doing any of the things we've mentioned previously. So, and that was a crazy fast run through the evidence as I could look it up.
It was, but I guess two things. One is, some of this is a bit conceptual. So thinking about best bang for your buck, as you say, and high and low value preventive care, and just the importance of addressing that when we're thinking about our own clinical practice, but certainly in teaching registrars. And people can have a look and should have a look, I think, at some of those figures and can actually use them in teaching. So just, I guess, the supervisors are probably thinking, well, what do I take away from this from a point of view of bang for buck? You often have 6 or 8 potential targets for preventative care in an individual patient. Would you be going right back to the beginning there about making sure their blood pressure's well managed and that they're not smoking as the kind of...
For me, I guess I think even the concept of teaching your registrar that this variation in high yield does exist, and please, it's an ongoing learning. The evidence for virtually every slide I've mentioned, aspirin probably won't change much now, but most slides I've mentioned, the evidence will keep rolling in throughout their careers, and the concept that they need to keep up with it if they're going to be a good doctor. And the other thing is that just the concept that not everything they do is equal. I sometimes think a registrar who sort of has a spiel on, vitamin C helps prevent colds or something. That's sort of an okay spiel if they have a bit of evidence, but for them to put a lot of effort into telling that to everyone with a cold, to me, it's just very low yield medicine. Yeah. Even if it's maybe true, if they can find a study that 2% does increase or whatever, to me, it's you've only got a certain amount of time with the patient and spend it well. And I think if we can teach our registrars that's the take-home lesson.
I guess in summary, certainly the screening side of things, I think, is that there are good evidence-based guidelines around, and that screening tests can cause harm. They will cause harm if we use them inappropriately. And I think it is really important to scrutinise registrar behaviour and how they are screening patients. And I guess, secondly, as Justin's just said, I think thinking about preventive care, I can't remember the figure now, but there was some study quoting if we implemented all the prevention that every patient demanded in a normal day, would be there, until the next night. Like literally, it's just an impossibility. So we have to We have to prioritise where we invest our time and energy. This is about some sort of the broader conceptual things that we hope will guide those conversations with registrars. And really, probably the last thing is just to think this is a very, very different aspect of practice from their hospital-based care. They don't think prevention, they don't prioritise prevention, whereas it's the bread and butter of our practice. And so we're doing a real disservice if we're not embedding that into the teaching we do. Thank you so much all, and a big thank you to you, Justin, who we love having on GPSA webinars. Your enthusiasm shines through very strongly, and also your, if anyone who observed those slides went fairly swiftly through, you'll see there was a lot of work in pulling those together, but hopefully they'll be able to be utilised in another setting at another time. But thank you so much for your contribution and pulling this together.
Great. Thank you all. Been wonderful. Good night all.
Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.